This is how we'll go over it. Limitations of two-stage exchange, limitations of single-stage exchange, a little bit about what is 1.5, then its advantages, contraindications, surgical technique with a video, and the review of literature. So though we call it a gold standard, the two-stage exchange, it's been there for last 40 years. We've all seen that the infection eradication rates are variable in different studies from 73 to 96%. Now calling something a gold standard and having just a 73% success rate means there are going to be alternatives. So the other disadvantages are interim functional outcomes being not as promising, multiple hospitalizations, increased cost, delayed recovery. When it comes to single stage, now single stage is also not a new procedure, though we hear less of it. It's been there just 4 years after the two stage came in 1987. The single stage also came in, and it has limitations too. The recurrence of PJI after single stage is devastating. Apart from challenges of revising it, significantly adds to morbidity and the financial burden. High failure rates in fungal and gram-negative have also been seen, as well as those with medical comorbids. Now, what is this 1.5? 1.5 revision TK offers the patient a single surgery. So it's actually one surgery with a well-functioning prosthetic articulating spacer. So that's the difference. So it's a single surgery with a prosthetic articulating spacer. The prosthetic articulating spacer is intended to remain for an indefinite period. And revision only happens when there's reinfection or deterioration of functional status or construct failure from aseptic loosening. The advantages, of course, because it is more cost effective than two stage since there's just one procedure, there's more bone preservation, and again less morbidity because it's a single stage procedure. And if a second stage is ever needed, removal of spacer is much easier than removal of the revision implants of a single stage in case of recurrence of infection. Now, the contraindications are massive bone loss, loss of extensor mechanism, collateral ligament insufficiency, where there's gross instability, failure of multiple articulating previous spacers, and some relative contraindications as well. Now, when it comes to surgical technique, from pre-op considerations to the exposure, implant removal, and debridement, all of these have the same principles as we would have in a stage 1 revision. And once a clean wound bed is established, the entire surgical team re-scrubs, re-gowns, and re-gloves. All previous surgical instruments are isolated on a separate table and noted as contaminated. Then a new sterile setup with new instrumentation is obtained for implantation. So this part is similar to a single stage. Now, in terms of reconstruction principles, since we are thinking that this should last for a long period of time, these are the basic principles. Tibial cut is perpendicular to the mechanical axis. The rotation is based on the tibial tubercle or free-floating method. The femoral rotation, since we have the epicondyles, it's a very crude way, but that is how it's done. Point being that it's never along the PCA because, of course, the bone loss is so much. Femoral size ensure that the PCO is restored. Soft tissue releases may be performed. And now for the tibia, a Schanz pin can be drilled into and attached to the bottom of an all-poly tibia to act as a stem if needed when the bone loss is significant. So I'll just show this video. Yeah, you can see that all-poly tibia over there, and then you drill into the back of it, into the tip of this all-poly tibia to ensure that you are able to put in a Schanz pin, and using again the drill, you can see the introduction of this, and then you can leave it in situ like that. Once that's attached, you can just trial with this. Of course, in the video, it's already been, the sizing and the trialing has already been done. So just showing you how it's put on there. Yeah. And that's your femur. So it's as simple as that. And then, of course, the cementation. So nothing different there, just the regular cementation. Ensure that the cement doesn't go all the way down into the Steedman pin. And basic cementation on the femoral side. Now post-op, since it's a functioning spacer, that's what it is, functioning prosthetic spacer. So therefore, full weight bearing and full range of motion. If there is concern for soft tissue compromise, knee immobilizer or hinged knee brace locked in extension for 2 to 6 weeks may be used until the tissues settle down. Post-op, broad spectrum antibiotics are continued IV and transition to culture specific therapy for an average of 6 weeks or until you get a downtrend of ESR and CRP. Now, how is it faring in the literature? Multiple studies have been done. This is Journal of Arthroplasty to 2021. So you have a 16% reimplantation rate, 90% infection eradication rate at a 2.7-year follow-up. And this one in 2020, 26% reimplantation rate for a 90% infection eradication at 3.7-year follow-up. And this study compared it with a two-stage exchange, and the infection rate, knee ROM, and quality of life scores were not statistically different. Journal of Arthroplasty 2019, 38.6% reimplantation rate, 78.9% infection eradication at 4.4. So the comparison of 1.5 versus two-stage exchange, it demonstrated non-inferiority in reinfection, reoperation rates, and functional scores. And another one having similar kind of results. So the take-home message is that 1.5 stage exchange is a good option for managing chronic PJI. Infection eradication rates are comparable to two-stage exchange. Decreased cost, morbidity, and mortality make it a viable option. Easier second surgery if needed. And by that time, the patient is also physically and mentally better prepared. Thank you.